Hello everyone in CardioMind's channel and welcome to the fourth video in the guidelines of ventricular arrhythmias and sudden cardiac death. And today we are focusing on the acute management of ventricular arrhythmia in the ER and in the CCU or ICU. The first question that we should ask ourselves when we deal with a patient with ventricular arrhythmias or sudden cardiac arrest: are there any reversible causes to be treated or not, as they may account for up to 50% of cases of sudden cardiac arrest. For example, electrolyte imbalance like hypokalemia, which may trigger QT prolongation resulting in ventricular arrhythmias. Even the rapid rise in extracellular potassium may lead to asystole and cardiac arrest. Hypocalcemia and hypomagnesemia may also result in QT interval prolongation. Severe bradycardia may result in brady-dependent VT by the prolongation of the QT interval with the increase in RR interval. Ischemia, of course, or coronary vasospasm are one of the most common reversible causes to result in ventricular arrhythmias up to sudden cardiac arrest. Fever, in case of sepsis, may also be one of the causes. Acute starvation or extensive dieting, like an anorexia nervosa, may be a reversible cause. And of course, the drug-induced arrhythmia, like the medication known to induce QRS prolongation, like sodium channel blockers, or QT prolongation, or other medication causing electrolyte abnormalities like potassium-losing diuretics. Please note that the patient who survives sudden cardiac arrest in the context of reversible cause may have a high mortality rate, as in a recent large observational study on the survivors attributed to a reversible causes, subsequent ICD implantation was associated with lower all-cause mortality, except in case of aborted cardiac arrest in the presence of acute myocardial infarction, as here they don't benefit from ICD implantation. And so the need for prophylactic ICD implantation should be considered based on the underlying heart disease and an individual evaluation of the future risk of life-threatening ventricular arrhythmias and sudden cardiac arrest in order to decide on whether this patient would need ICD or not. So the recommendations are to withdraw any offending agents that may result in drug-induced ventricular arrhythmias, investigate the reversible causes like electrolyte imbalance, ischemia, hypoxia, fever in any patient with ventricular arrhythmia, and despite a possible correctable cause for the presenting ventricular arrhythmia, the need for ICD should be considered based on the individual risk assessment. Let's remind ourselves with an important rule: any patient with sustained monomorphic VT should promptly terminate it, even for hemodynamically tolerated VT, as rapid hemodynamical deterioration may occur, resulting in cardiogenic shock up to bradyasystole, or in some cases it may degenerate into VF. In the 2015 ESC Guidelines, which were the previous guidelines for management of patients with ventricular arrhythmias, they stated that any ventricular tachycardia should receive immediate electrical cardioversion by synchronized DC shock regardless the hemodynamic status. So they stated that DC cardioversion is a class 1 for any patient with sustained VT and hemodynamic instability. You can give IV medication for patients with hemodynamically tolerated VT in the absence of structural heart disease, as you suppose that they are idiopathic VT or fascicular, like giving IV flecainide, conventional beta blocker, verapamil, or amiodarone, and this was class 2B. Was there any change in the 2022 ESC guidelines? They stated that DC shock is strictly indicated in any patient with hemodynamically unstable VT as a life-saving solution. But there was a rising concern about the risk of sedation or anesthesia in hemodynamically stable VT, especially if you are doing it in the ER, so you may not have an available anesthesiologist. That's why they shifted toward IV medication sometimes for patients with hemodynamically tolerated VT. In the famous PROCAMIO trial, they stated that IV Procainamide was associated with a higher proportion of VT termination and fewer MACE when compared with IV Amiodarone. That's why it's gaining its popularity for acute management of VT. However, you should not use IV Procainamide in those patients, as it may precipitate hemodynamic instability or severe bradycardia, like severe heart failure patients, acute MI, end-stage renal disease, severe sinus node dysfunction or AV conduction disease, hypotension, or Brugada syndrome, because you are speaking about a sodium channel blocker medication from the class 1A antiarrhythmics. This diagram illustrates how to manage a patient with regular white-QRS complex tachycardia, as this is the first diagnosis that you adopt when you see a patient with white complex tachycardia. That may be VT as a first possibility, but also it may be SVT with apparency. First of all, you should assess the hemodynamics. If the patient is hemodynamically unstable, go immediately for synchronized cardioversion or even defibrillation in case of pulseless VT and cardiac arrest. And please remember that cardioversion is not indicated in patients with repetitive non-sustained VT, as they are self-terminating. But if the patient is hemodynamically stable, so take a rapid history, rapid examination, and perform ECG to capture the tachycardia. You can give adenosine or start vagal maneuver if the possibility is suggested for SVT with apparency. And remember that adenosine does not only terminate SVT, it may terminate idiopathic VT, suggesting cyclic AMP mediated triggered activity as a mechanism. After that, you can decide whether this patient is known or suspected to have structural heart disease. If there is no suspicion, so you are dealing with idiopathic VT. If the ECG suggests vesicular VT, you can give IV verapamil. If not responding, go for synchronized cardioversion. If it is known to be outflow tract VT, you can use IV beta blockers. If not responding, go for synchronized cardioversion. It may be other type, or you are not certain of the diagnosis or etiology, so you need to assess the anesthetic risk for cardioversion. If there is no concern regarding sedation or anesthesia, so go for cardioversion even if the patient is hemodynamically stable. But if there is a concern that may be dangerous in specific patients like elderly or patients with multiple comorbidities, you can give IV Procainamide, which is class 2A, or you can give flecainide, ajmaline, sotalol, or IV Amiodarone as class 2B, so they are the second choice after Procainamide, or if Procainamide is not available, I can use one of them. And remember here that I mentioned flecainide, sotalol, ajmaline because I am dealing with a patient with no suspected structural heart disease. But what about if the patient is known to have structural heart disease by history, or based on the symptoms and examination he is suspected to have this? In this case, you need also to ask yourself whether there is an anesthetic risk for cardioversion or not. If there is no concern, go for synchronized cardioversion. If there is a concern, so you can use IV Procainamide as a first choice, or if not available, go for IV Amiodarone. If not responding, go for cardioversion. So you need to assess the benefit of cardioversion against the risk related to anesthesia and sedation. This is the main difference in the acute management of VT in the 2022 from the 2015 guidelines. So the recommendation that DC cardioversion is recommended as a first-line treatment for any patient with hemodynamically not tolerated sustained VT, and it is recommended also as a first line for patients presenting with tolerated VT, provided that the anesthetic and sedation risk is low. In patients presenting with hemodynamically tolerated idiopathic VT, we can use IV beta blockers for RVOT or outflow tract VT, or verapamil for vesicular VT. If the patient is presenting with regular white complex tachycardia with hemodynamic stability suspected to be SVT with apparency, you can use IV adenosine or vagal maneuvers. In patients with hemodynamically tolerated sustained monomorphic VT with known or suspicion of structural heart disease, you can use IV Procainamide with 100 mg bolus to be repeated after 5 minutes if no effect, and maximum dose of 500 to 750 mg. But please avoid rapid infusion to avoid hypotension. If you don't establish a diagnosis or an etiology underlying the sustained monomorphic VT, you may use IV Amiodarone, but please consider the risk of hypotension or bradycardia with prolonged Amiodarone infusion. And in patients with hemodynamically tolerated VT in the absence of significant structural heart disease, you may use IV flecainide, ajmaline, or sotalol based on the absence of structural heart disease. In refractory cases, you can adopt manual overdrive pacing, which has the same idea as terminating the tachycardia in EP study. It can be performed in patients with an ICD to terminate the VT if it is below the ICD detection rate, and it can be performed by a programmer but in a monitored place. And the big no that IV verapamil is not recommended in wide complex tachycardia of unknown mechanism. If it is VT with an underlying structural heart disease, it may precipitate hemodynamic deterioration. The second part of our video today is how to manage electrical storm, which is a ventricular arrhythmia, either VT or VF, occurring 3 or more times within 24 hours, separated by at least 5 minutes, each requiring termination by an intervention. Incessant VT is continuous sustained VT that recurs promptly despite repeated intervention for termination over several hours. We mean by termination either pharmacotherapy or DC cardioversion. The big problem is that patients with an electrical storm are prone to psychological disorders, heart failure, decompensation due to the multiple DC shocks delivered, mortality, of course, because in some cases it may result in refractory VF, ranging from recurrent asymptomatic VT episodes terminated by ATB in patients with an ICD, or life-threatening electrical instability with ventricular arrhythmia that recurs frequently after multiple shocks. And sometimes the ICD shocks may be inappropriately delivered, like for SVTs or AF, non-sustained VT, lead defect, or electromagnetic interference. So what to do urgently if you see a patient with electrical storm in the ER, CCU, or ICU? First of all, disable all the ICD therapies either by programmer or putting a magnet on the device, provided that the patient is in a monitored place with a nearby crash car, and you start ALS in case of hemodynamic instability resulting in pulseless VT or VF. Check the reversible conditions that may contribute to the initiation and perpetuation of VT. Most importantly, coronary ischemia or electrolyte imbalance, which may need immediate action, like transferring the patient to the cath lab if the patient is suspected to have acute MI, or giving IV electrolyte replacement, like in case of severe hypokalemia, hypomagnesemia, or hypocalcemia. And then the further management depends on the type and etiology of the ventricular arrhythmia. There is a multifaceted approach to manage electrical storm depending on multiple therapeutic lines. First of all, ICD reprogramming by increasing the number or efficacy of the ATB trial before switching to ICD shocks, turning on the ATB during charging in the VF zone, which may help to terminate the VT during charging, so minimizing the need for shocks, optimize the SVT discrimination maneuvers in case of inappropriate shocks for SVT or AF, increase the number of interval detection to diagnose a sustained VT necessitating therapy in case of inappropriate shocks for non-sustained VT. We need to start immediately antiarrhythmic drug therapy, starting with beta blockers, preferably the non-selective ones like propranolol, and then we use IV amiodarone plus minus when we need IV lidocaine if the patient is not controlled on amiodarone. Landiolol is an ultra-short-acting beta-1 blocker which was found to be effective in case of recurrent hemodynamically not tolerated VTs resistant to amiodarone. And the use of Procainamide or quinidine depends on the specific situation, type of ventricular arrhythmia, and the underlying etiology and mechanism. Mild to moderate sedation may be necessary to reduce the psychological stress caused by the multiple DC shocks and so reduce the pro-arrhythmogenic sympathetic tone, which may be a contributing factor to perpetuation of ventricular arrhythmia. But in some cases, we may need an anesthesiologist in order to start deep sedation, intubation, and mechanical ventilation in case of intractable electrical storm with multiple shocks in a few hours despite available antiarrhythmic drugs. Autonomic modulation may be also performed in specific cases by an anesthesiologist, like percutaneous ganglionic stellate blockade, thoracic epidural anesthesia, left cardiac sympathetic denervation. All of these help to reduce the sympathetic tone and so interrupt the perpetuation of ventricular arrhythmia and reduce the psychological distress caused by the severe pain of DC shocks. Then we will think of catheter ablation, which may be necessary in case of sustained monomorphic VT, which is the most common arrhythmia underlying electrical storm and mostly associated with structural heart disease due to scar-related re-entry. Ablation here results in significant reduction in VT and the electrical storm recurrence, improved long-term survival, and also it may be necessary in case of incessant slow monomorphic VT, as here it is preferred over the antiarrhythmic drugs, which just further slow the VT. And recurrent symptomatic episodes of polymorphic VT or VF triggered by a similar PVC morphology may benefit from catheter ablation. And in refractory cases, mechanical circulatory support may be necessary for hemodynamic stabilization if conventional therapy fails, as in a recent meta-analysis, it showed substantially lower mortality with prophylactic mechanical circulatory support treatment. It may also be used to provide circulatory support during ablation of hemodynamically not tolerated VT, as here the patient may develop hemodynamic instability during induction of the VT. This diagram shows how to manage a patient with electrical storm or repeated ICD discharge. First of all, you should assess the rhythm and interrogate the ICD to decide whether this patient is receiving inappropriate or unnecessary therapies or they are appropriately delivered. If they are inappropriate therapy due to AF, SVT, or lead oversensing, so you need to program and optimize the ICD parameters, disable the ICD by magnet placement if programmer not available, and you need to have a specific treatment for AF or SVT. But if the patient is having recurrent non-sustained VT, so also you need to optimize the ICD parameters and disable the ICD, because also here it is considered inappropriate therapies. If you excluded these two conditions, so you are truly dealing with an electrical storm. Assess the hemodynamic status. If the patient is hemodynamically unstable, so you should start ALS, including external cardioversion or even defibrillation in case of pulseless VT or VF. But if the patient is hemodynamically stable, so go for sedation, either mild to moderate or in some cases deep sedation if necessary. Assess the type of ventricular arrhythmia, whether it is polymorphic or monomorphic ventricular arrhythmia. But if it is polymorphic, so you should think of the underlying etiology. If it is due to acute ischemia, so you should manage it as a STEMI, as this patient may need immediate primary PCI. If there are external precipitating factors like reversible causes, so treated according to the underlying condition and the structural heart disease if present. If it is polymorphic ventricular arrhythmia triggered by unifocal PVC, you should think of catheter ablation, and we may need quinidine. However, there are no data on the effect of quinidine on PVC-triggered polymorphic VT in patients with cardiomyopathies. In case of acquired long QT intervals, so remove the precipitating factors contributing to QT interval prolongation. Start IV magnesium or potassium according to the detectable electrolyte abnormality. Isoprenaline infusion may help to reduce the QT interval and interrupt the electrical storm. Pacing may be needed in case of predicate-dependent VT. But if it is due to primary electrical disease, famously known as channelopathy, if it is due to Brugada or early repolarization syndrome, we can start isoprenaline, quinidine, or catheter ablation. In case of idiopathic VF, we can also use isoprenaline, quinidine, verapamil in some cases, and catheter ablation of the PVC triggers. So far we can use quinidine in Brugada syndrome, idiopathic VF, and also in short QT syndrome. In case of long QT syndrome or catecholaminergic polymorphic VT, beta blockers are beneficial. Pacing may be needed if bradycardia or post-extrasystolic poses facilitate the initiation of polymorphic VT or BF. IV magnesium or potassium may shorten the QT interval, then antiarrhythmic according to the underlying disease, and autonomic modulation like left cardiac sympathectomy may be helpful. If it is still recurrent polymorphic VT, we may go for deep sedation and intubation, and in case of hemodynamic instability, mechanical circulatory support. If it is monomorphic VT, so we need to check the VT burden. If it is still high burden, in case of a clinical scenario of very frequent ventricular arrhythmia episodes requiring ICD shocks when only short periods of stable rhythm can be achieved, so you need to go for ICD programming optimization, beta blockers and sedation, and IV amiodarone if still recurrent electrical storm due to monomorphic VT, so arrange for catheter ablation. Deep sedation and intubation may be needed, autonomic modulation, mechanical circulatory support, or overdrive pacing by pacing with a slightly higher rate to temporarily suppress the slow recurrent or incessant sustained monomorphic VT. But if the VT burden is low, like a clinical scenario of repeated ATBs or ICD shocks followed by stable rhythm, optimize the ICD parameters if the patient is not on amiodarone or it is not desirable. So start antiarrhythmics according to the underlying heart disease, but if it's still recurrent, go for catheter ablation, or if the patient is still developing VT despite amiodarone, so immediately go for catheter ablation. So the recommendations for electrical storm, that mild to moderate sedation is an essential line of therapy to reduce psychological stress and so reduce the sympathetic tone. Antiarrhythmic drugs starting with non-selective beta blockers in combination with intravenous amiodarone is recommended in patients with structural heart disease and electrical storm unless contraindicated. IV magnesium with supplementation of potassium is recommended in patients with torsade de pointe, which is polymorphic VT with long QT interval. Isoprenaline or transvenous pacing is important to increase the heart rate in patients with acquired long QT syndrome and recurrent torsade de pointe despite the correction of the precipitating conditions, and magnesium. Deep sedation and intubation should be considered in patients with an intractable electrical storm refractory to antiarrhythmic drugs. Catheter ablation is a class 1 recommendation in patients with incessant VT or electrical storm due to sustained monomorphic VT refractory to antiarrhythmic drugs, and class 2A in patients with recurrent episodes of polymorphic VT or VF triggered by a similar PVC morphology, not responding to the antiarrhythmic drugs or not responding to coronary revascularization. Quinidine, as we mentioned, may be considered in patients with coronary artery disease and electrical storm due to recurrent polymorphic VT if other antiarrhythmic drugs failed. Autonomic modulation may be considered in patients with electrical storm refractory to medication if catheter ablation is not effective or not possible. And in starting, mechanical circulatory support may be considered in case of drug refractory electrical storm and cardiogenic shock. So we reached the end of our video today, and our take-home message that acute management of VT is not just to terminate the VT simply. You need to correct the reversible causes, diagnose the underlying disease and mechanism, as based on this you can decide the further management, and consider always the risk of sedation or anesthesia with DC shock for hemodynamically stable VT before rushing for cardioversion. Thank you very much for watching this video, and we are going to discuss the long-term management of ventricular arrhythmias.